So the work that you've done on the outcomes reporting tool, it's fairly recent. I mean, it looks like it's relatively new work that's been done. And how has this changed the way you think about the day-to-day practice and the research you're doing? So are you now routinely incorporating this tool? And what's the recommendation for this? I mean, has this tool now been endorsed by multiple societies? Is the plan that it gets endorsed by multiple societies so we start using it much more? It seems like standardization is very important.
I think it's not using because I'm looking for different papers, and really I don't have. I make this table in the article of my hospital, but I make it. But in general, people don't publish the table like the work group wants, no, because it's important that all the sum of the patients, some 100%, because sometimes there are some spatial retention, no? Sometimes there's no clarify how patient is in. If there's no patient, you need to make 0 patients, no? Sometimes it's not well defined. You can search in the article the different tiers, but publish like a table like this that they consider and they recommend in general is not, it lacks in the different publication. It's relatively recent. I think it's very important to know how to use, because the starting point to assessment is very important. It's in the beginning of the first treatment, and well, maybe need to redefine, because maybe spatial rotation is considered a failure, but I don't know, because some patients have a retained spatial and they are comfortable with this retained spatial, and they classify it as a failure of treatment. I think it's important to redefine, sorry, but I think it's very, very important to use, because improves totally the transparency of the publication.
Yeah, it looks as though from the ICM meeting, it was based on a consensus, right? So it was developed, and then a number of experts looked at it and said, yeah, we generally agree 80% of the time, and therefore it's been adopted. So it means to me there's lots of opportunity for it to be used. And then also, there may be revisions made, as we learn more about it. The thing that I always remember about designing studies or evaluating, outcomes is we have to ensure that patients are at least part of the, we call stakeholder group, right? We've consulted at least with patients to understand which of these types of outcomes matter the most. And to your point, what we might consider a failure, a patient may consider a success. Similarly, what we consider a success, a patient may consider a failure. And I do think that's where there might be real opportunity to further develop this. I wonder if there's anyone else with questions or any comments related to this work. I think it's really important that we do standardize. So I commend you for presenting this work, both you and Ernesto. I think it's important that we do this.
Mm-hmm. Totally agree. Yes, this work group says that it's important to listen the patient expectations, no? Because you say before, sometimes maybe a patient with a spatial rotation is happy because there's no pain, no?
Yeah, right.
There's no evaluation of the pain. I think the problem is that there's no validated functional scale. There was no agreement in the published by Diaz Ledesma. There's no agreement in the functional level. I don't understand why there's no agreement in functional status, because it's very important to ask the patient of the clinical status, no?
Got it. No, that makes sense. That's helpful. Sapper, I think you were going to say.
Go ahead. That is why we are very happy that one of your big areas of interest, Mo, is infection, actually.
Yeah.
One of your big area of research.
Yeah.
So, there's many things to do, and there are a lot of controversy, probably even more than in trauma.
Oh, much more. And I think, when we think about joint replacement surgery, principally, infection is the most, clearly, I mean, in my mind, it's the most devastating of the outcomes, the most feared outcome, and the one in which, even though it's rare, we should be putting a lot of value on it, right? And trying to find ways to make the 3%, 1%, or the 1%, 0.5%, right? So that's where I think we have to really focus on. The same way that we focus on heart attack and death after heart attack the same way. I mean, we took, we've been able to, with lots of investment, large trials, completely change survival, right? After a myocardial infarction. We can do the same in joint replacement. I just think we have to work together to do that.
Mm-hmm.
Sepper, you had a comment.
The proof is that in 10 years, there are 6 different definitions from of one complication. It is not possible. There was a study from Holland, I think, that about treating surgically the acute infections, and there were 70 different models of treating acute infection. So situations are not standardized.
Understood. Sabra, you had a question?
Yeah. Hi, Ernesto and Joan. Good to see both of you. Thanks for a great talk. I have a question.
Hi.
So some of these criteria include some things that aren't universally available, and even to us here in Canada, things like alpha defensin are not routinely available as a diagnostic tool. As Dr. Bandari alluded to, kind of trying to take a global lens on this, and as we move forward, what are your thoughts on having things that are included in the diagnostic criteria that aren't even available in some, high-income countries, let alone some of the lower and middle-income countries that are now starting to do more and more arthroplasty?
Yeah. Regarding the serological and synovial test, fortunately for this definition, as for other definitions, it is not necessary to do all the tests. All the tests are not necessary. For example, alpha defensin that cost $700 in the States, probably in Europe it is around 500 euros. It is necessary to do it routinely. J. Parisi has reported the utility of the Leukocytes terasa that has the same predictive value of the same weight after statistical analysis, the same score of the alpha defensin. It's 3 points for alpha defensin, 3 points for Leukocytes terasa, and every strip of the Leukocytes terasa test cost $0.16. And not all tests are needed. Not all tests are needed. Yeah.
Yeah, I mean, that's a good, I think it's a very good, it's a very good point though, right? We raise is when we're thinking about outcome measures and we're thinking about diagnostic measures, we just have to be, realistic about if we're going to do the large global adoption, we're going to have to find simple ways in which, where resource limited countries can still have the same efficacy. But that's an interesting point you raise, Sepper, because in a large trial, for example, we have a real opportunity to test out some of these measures in a variety of countries, and we can look at the relative, specificity and sensitivity of these tools in diagnosing the outcome or, measuring it in the context of, sort of real world studies, right? If we do these large pragmatic studies. So I agree. I think that's a really interesting approach that's been provided, but I also think there's lots more opportunity for us to be exploring and further developing, right? Or confirming or refuting some of its overall value. In the context, though, of, let's say, designing a study, a large study, when we talk about the diagnosis, for example, of infection, I mean, that is fundamental to most of our studies in terms of, well, if we're looking at, infection as a diagnosis, we have to get at least a standard approach to measuring it so we can actually decide how big our study should be and how valid our study is going to be. We don't want false positives, and we certainly don't want false negatives. So is the diagnostic criteria that's been provided sufficiently global from your perspective that you could apply it in a large clinical trial around the world? Again, back to Sepper's point, I guess we'd have to figure that out and find a strategy for this. I mean, the simplest way to do it is looking at your tier 3, right? Something that requires an intervention like a reoperation probably is a little bit more of a discrete measure, a little bit more, a little less common, but it does help us in terms of when I think about designing studies. If you're able to look at the tier 1, tier 2, tier 3, it does give you a lot more opportunity, right? Sort of there's the management of infection that is done non-operatively versus the operatively managed. You pool those together, you can have more infections, truthfully, and probably fewer patients. Because right now, the studies that we'd have to design, as you know, both would be tens of thousands of patients. If we look at just the most, invasive of infections that require surgery, right? Which is usually a few percent, not several percent. I don't know, just my thoughts.
An interesting thought that Ernesto says is the overdiagnosis. This is also a problem, no? Because sometimes an overdiagnosed patient, I know patients I'm recording, thinking about some patients that we have an overtreatment, and this is a problem. This because is a problem, not good diagnosis, but also a overtreatment. It's very important that to have this consideration. No, Ernesto, what do you think about the overtreatment of these patients?
Yeah, I invited to this webinar to some members of the FG Society, and infectologist for Netherlands was connected, but she had another webinar and she was going to talk, but she has disconnected now. And she told me you don't have said anything about the last Congress of that was 1 month ago. There was some reports that say the opposite of the abstract that have been presented in America 2 months ago. Yes, there are different groups that are working in different directions. The ideal situation is that these relevant groups will work together to make a very clear and precise definition that will have extremely valuable for the whole world, from high incomes and low incomes countries, to have a better possibility to do a precise diagnosis and not overtreat or inclusively undertreat patients. So it's necessary to get together to the orthopedic community that do research or are interested in this field, in this catastrophic complication, to put the ideas together to make good definitions, to establish what is a good outcome or bad outcome, and so on. Yeah.
No, I mean, it totally makes sense. I mean, this is a devastating, issue for patients. So managing it and being thorough and careful about it makes a lot of sense. I wonder if we could just invite you both in turn, just to give a closing statement overall. As you think about the work that you've been doing and where we need to go for the future. I wonder if both Ernesto and Joan, you could give a final comment to us before we adjourn this wonderful session.
Yeah, my final comment is what I have previously said. We have to put apart politics and some not scientific interests, and to work together, relevant groups from the world, to make better diagnosis and better strategies for prevention and treatment of these devastating complications. And we need your collaboration also more for this.
Thank you. Joan?
Also, I think that this is a very important problem of our departments. I said before, in the first quarter of 2018, we reached 6% of infection. This is very catastrophic. We need to implement different measures. The first measure that we implemented is medical education for all the residents, and also to improve standardization. I think it's very standardization, the procedures, etc. But we need also to standardize definition, standardize success of treatment, to be very transparency, because the slide that I put before in my presentation, where there was Javad Parvici, we says to him, and they said that we are very worried, and he congratulations to us, no? He gives congratulations to us because we are very honest, no? And we speak transparency with our bad results. I think it's very important to have your results, because sometimes the people or the departments don't have really the results of their infections. But it's important to have an external audit. We are an audit from epidemiological department. I think it's very important. And I think it's very important to do research, medical education, and improving continuously to these different aspects. No? Also, it is very important to be transparency in publication. I think it's very useful, this outcome reporting tool, because this improves transparency and makes all the people speak the same language, no? Because it's very important to standardize this. I think this is very important.
Right. And I think on that final note, it just reminds me that, and I say it all the time, right, is that the evidence-based practice always begins and ends with the patient. So when you see something happen in your clinical practice, I think we need to honestly, as you've just done, evaluate what's happening and then develop the appropriate tools to limit it from happening in the future, right? To standardize ways in which we can understand sort of the pathways of which we might be having some of these infections, and learn, from those issues towards, improving overall care, but not just for us, but for all the other institutions. So the work that you're doing, I think, should be commended. And on that note, I thank you all. Thank you, those of you who attended this session. We'll make sure we have the recording available as well. The transcripts are available in short order, and we'll make sure we widely disseminate this information. So to all of you, have a wonderful rest of your evening. And for some of us, have a wonderful rest of your day. Thank you very much, everyone.